Okay, so this demonstration is going to be for intravenous pyelogram, otherwise known as IVP. Your book also refers to an IVU, which is intravenous urogram, but that indicates really just a study of the ureters, and we are studying the kidneys, ureters, and bladder in this study, so we call it an IVP. It involves the patient doing some type of prep to get ready for this, usually just nothing by mouth prior to midnight before. And no chewing gum, no, anything that could cause like gastric juices to start flowing and everything, because we ideally want the bowel to be as free of material as possible so that it doesn't obscure the kidneys. And then just prior to bringing the patient into the room, I would have them go into the restroom and void so that their bladder is empty, because once the contrast is processed by the kidneys and enters the bladder, if the bladder is already full of urine, it could dilute the contrast. So this patient's changed into a gown. Everything from the waist up has been removed so that I won't have any bra straps or anything in the way. She's voided, and then I would bring her into the room and first do a scout film. Okay, Raina, I need you to lie down up here on your back with your head on the pillow. That's good. Okay, I'm going to check to make sure that it looks like her mid-sagittal plane is down the center of the table. This is called a scout film because a scout, and I'm sure this probably started as a military term, the scout is the one that goes ahead to see if everything is clear, and so they just adopted that term for this. The scout film is going to make sure that her bladder looks empty and that she doesn't have a lot of gas or maybe undigested food that would obscure us seeing the urinary system. So I'm placing my right marker as well as a marker that indicates this is a scout film. This is a kidney, ureter, and bladder shot, KUB, done at 40-inch SID. And I need to be sure to include the kidneys, ureters, and bladder. If you have a really tall patient that isn't going to fit on a 14x17 image receptor, you may need to do two scout films, one that absolutely includes the kidneys, and then maybe come back and do a second bladder shot on a 10x12, because the radiologist needs to see the entire area prior to contrast injection. Okay, I'm going to press on your waist here. I'm going to feel for top of iliac crest, and I'm going to center right at the crest. Her kidneys are probably located right around the last rib, which I feel here, so I'm pretty confident that I'm going to see her kidneys and her bladder. If you weren't quite sure, you could raise up your SID just a little bit. And now definitely I'm going to include bladder and kidneys on here. So that's what I'm going to do here. I'm open a little bit wide, so I would collimate down. Shielding per department protocol. If this was a male patient, I could shield. Female patient, I really can't because I do need to see her bladder, but if you had a male patient, you could place a shield below the field of view. All abdominal x-rays are done on exhalation, so Raina, I need you to take in a breath, blow it all the way out, keep it out, stop breathing, and expose. So I would take this scout film, process it, show it to the radiologist, if that is the department protocol. Sometimes IVPs, the radiologist doesn't want to be bothered. They will just we follow a protocol. So based on her weight, I would give her so many cc's of contrast or mLs of contrast. Also, depending on the department protocol, you as a technologist with a venipuncture certificate might be the one to be doing the upper extremity venipuncture and administration of the contrast, but it requires that a physician be in the department, because on the rare instance where the patient had a contrast reaction, you have to have immediate access to a physician because they need to give the order to administer Benadryl or whatever other contrast or whatever other medication is necessary. Also, prior to injection of contrast, I would have taken a history, making sure that she's not allergic to iodine, which shellfish actually has a high concentration of iodine, so that's sometimes one of the questions you ask, you know, are you allergic to shellfish? Because if they can eat shrimp and crab and things like that and have no problem, then they probably don't have an iodine sensitivity. I'd make sure she had nothing to eat or drink since midnight. And if her scalp film looks clear, then I would set up to do the upper extremity venipuncture, probably administering between 50 and 60 cc's of, Omnipaque or whatever contrast the department is using. And then as soon as I finished that contrast injection, I would somehow mark the clock in the room, or if I was wearing a wristwatch, I would mark it so that I would know what time I gave the injection, because our timed imaging is based on the time you injected. So after giving her the injection, I would swap out my IR for probably another 14x17, but this is going to be collimated to 11x14 or 10x12, depending on the size of your patient. And this is going to be what's called a nephrogram. This is probably going to be at about 1 minute. So 1 or 2 minutes, I would put my right marker and, whatever, if it was a 1 minute or 2 minute time on there. And I would column it now down to 11x14 or 10x12, depending on patient's size. So, looks about right. Make sure that your time marker is also in the field of view. And the kidneys are located around the level of L1-2.
And this is where your scout will help you.
Right.
As well.
You'll be able to see a shadow of the kidneys on the scalp film. Now that we've injected contrast, I should be able to see her kidneys very well. So I'm feeling for the last rib here. I know that crest is at L3. Kidneys are around L1. So between palpating last rib and crest, I should be in about the right place. And her kidneys are probably going to end up showing up right about here, with the right kidney being slightly lower than the left due to the liver on the right side. So I would do this on expiration, take that picture, and then again, you swap out, and as you watch the clock, you're going to just follow the department protocol, which is usually a 1 or 2 minute nephrogram, a 5 minute, 10 or 15 minute. Generally, by the time you're reaching 15 minutes, now I'm back at a KUB. So I'm 14x17 again. Now, I'll probably be doing 20-minute obliques. So I would put a 20-minute marker on here. And I'm going to take both an RPO and an LPO. So this is a 45-degree sponge. I'm only gonna roll her about 30, so instead of having her roll up all the way to the side and putting this under so that she rolled back and was at 45 degrees, I'm gonna put it like halfway under so that she rolls back farther and she's only about 30 degrees. So what I need you to do is bend your left knee, cross your left hand onto your right shoulder, roll away from me just a little. So instead of putting this all the way under her back, I'm just putting it about halfway so that when she rolls back, she's not quite at 45, she's more like 30 degrees. This is just an estimate, but what this does is normally the kidneys sit in the body about like this. So when she's rolled RPO, this kidney is in profile and this kidney is lateral, and you can see the ureter coming off. So that's the purpose of the oblique. And I'm gonna be centered at the crest, 2 inches medial to the elevated ASIS, because as long as I'm on the spine, I know I'm at the center of her body. So this would show the left kidney in profile and the right kidney collecting system and ureter. So I would do an RPO at 20 minutes, swap out the cassette, put my left marker and a 20-minute, because these two images should only take you about a minute to do. You're going to be pretty rapid doing this. Take the sponge out, have her roll LPO, do the second oblique at 20 minutes, and then probably wait another 10 minutes and then do a 30-minute KUB, and by then most of the contrast will have been processed through her kidneys, down her ureters, and should be collected now almost completely in her bladder. So the protocol I remember following, we would take all of these images, show them all to the radiologist, and he would direct us to either do a post void at that time, or he might say, wait another 10 minutes, show me a KUB at 45 minutes, and then make that determination. So it's a combination of showing the radiologist and following the protocol. So let me take this sponge out now. You can lay back flat. If by chance I miss the bladder on one or more of these images, I'm going to show you how to do a bladder shot. Generally collimate down to about 10 by 12 for this. Sometimes a little smaller, but you don't have to. 10 by 12 is fine. For her ASIS, and I know that about 2 inches down from her ASIS is mid-bladder, 2 inches up from her symphysis pubis. So I'm not going to palpate her symphysis. What I'm going to do is palpate ASIS and center about 2 inches below. Now I know that I've got the symphysis in there and her bladder should be centered right in the middle. So if you miss the bladder and you have to do a bladder shot, that's how you center for that. Okay, so we've done all of our imaging. Normally the needle's going to stay in the arm for maybe 5 to 10 minutes. And this is not a procedure where you ever leave the room and leave the patient alone. Let's say I just finished a 5-minute film and my next KUB was due at 15 minutes. I wouldn't go to the bathroom, get a cup of coffee, go chat with my friends. I'm going to stay in the room with the patient because I don't know yet if she's gonna have a contrast reaction. So you really need to, this is where you have small talk with the patient, you know, maybe get a little bit more clinical history from them. How long have you been having these problems? You know, reassure them that as soon as their imaging is done, they can go have a normal breakfast. You know, but kind of, we have to, this is our patient, we have to make sure that they're not having any kind of contrast reaction, and that would require us to administer Benadryl or, you know, any of the other drugs that we might have to give. So we leave the IV in their arm, you know, 5 to 10 minutes, because normally most contrast reactions, the severe ones, are gonna happen right away, and that way we still have venous access to administer drugs to counteract whatever problem they might be having. So she is fine. I've removed the needle from her arm and placed a bandage on it. Made sure that the bleeding has stopped. And by this point, she's been laying down for possibly 30 minutes. So when you have the patient sit up, make sure that they aren't dizzy. So I'm gonna sit her up and let her just sit on the edge of the table before I let her get up to go to the bathroom. So I'm gonna have you just sit up here for just a moment. Make sure that you're not dizzy. So the imaging's almost done. Once you feel like you're feeling well enough, I'm gonna have you get up and go into the restroom right here. The contrast that we injected into your arm has now traveled down to your bladder and collected there. So you should be able to void that out of your bladder. And then once you feel like you've emptied your bladder, come back in the room, and we're gonna do one additional image, this time with you standing. Okay. Okay, so while she's in the bathroom, I'm gonna set up for my upright post void. Anytime you hear post, it's the opposite of pre, so it's after something's happening. So a post void is after voiding. So I'm gonna do this at 40-inch. 40-inch SID. So this whole time I've been marking her right side because that's the side closest to me. Now with her in an upright position, you have to remember to switch and use your left marker. So I'm going to put my left marker here. I'm going to put another indication that says post void. And get this centered. And again, like we've talked about, you know, when I'm bringing my patient into the room, I'm kind of comparing my height to their height. So while she's in the bathroom and I'm setting up for this, I'm kind of adjusting this to where I think her crest might be, so that I don't have to do any major adjustments once she's back in the room. By 17. So, okay, Raina, this is the last one. Stand with your back against the board there. Once again, I'm going to feel for the top of your hips. So I estimated pretty close, but I'm going to need to come down. This definitely has to include her bladder. So at this point, I might even send her an inch below the top of her crest, because the book talks about how between supine and erect, the kidneys can travel as much as 5 to 10 centimeters. So I know her kidneys have dropped a little bit. They're closer to her bladder now, and I have to get the bladder. The post void has to include that. I wouldn't want to have to go back and do a separate bladder shot. So I'm going to send her maybe just an inch below her crest so that I'm sure I've included her bladder. Her kidneys have dropped a little bit. I've got my left marker, my post void on there. We're ready to go. Okay, Raina, one more time. Take a breath in, blow it all the way out. Hold it out, don't breathe, and expose. Okay, I would have the patient take a seat while I showed the final imaging to the radiologist. If everything looked good and he didn't want any further imaging, I would then, most likely the department has some type of post-procedure instructions to give to the patient, telling them to, increase their water intake to flush the rest of the contrast out of their system. If they're feeling any kind of symptoms at all, they should contact their physician immediately. But generally by this time, it's been 30 or 40 minutes. If they were going to have a contrast reaction, it most likely would have happened by now. She feels fine. I'm comfortable letting her go, and so I'd escort her to the changing room and then ask her if there was, any other appointments she might have in the hospital today, such as lab or anything, and then give her those instructions and let her go. So that is IVP.